Good evening, everyone, and welcome to the last webinar of our virtual conference. My name is Natalie Carter. I'm a consultant midwife and a very proud member of the vBICS committee. We had hoped that we might be joining you all to a delicious sit-down dinner right about now at our conference in Belfast, but it was sadly not to be. But we do hope that we will see many of you next year at the vBICS conference, which will again be in Belfast in November next year. Due to some illnesses, we do have a couple of changes this evening. Peter Yeh and Millie Hill are unfortunately unable to speak tonight. Thank you very much to Andrew Weeks, who has extended his own session to present on Peter's behalf. And we are delighted to also have Kemi Johnson joining us also. Thank you to them. I just wanted to remind everybody that if you could put any any comments or questions for the speakers into the chat function rather than using the hand function, that would be great. Thank you. So tonight we will discuss whether the medicalisation of childbirth has gone too far, become too medicalised in an attempt to reduce pregnancy risks. We will look at how we define those risks, how we communicate them to women, and how we offer support. I'd like to recognise that as well as birth professionals joining us tonight, we've also got women and their families who may have experienced giving birth in our services and who might find some of these topics difficult, triggering, and we would just like to say that if anybody feels they need to leave early, please feel free to do so. And if anybody feels that they need to seek out any support afterwards, then most maternity services do now have listening services where you can refer yourself into if you feel you need to have any more discussion about any of your own individual birth experiences. And likewise with any staff, if you yourselves feel like you might need to talk through any birth experiences, do speak to your employers and seek out support. Women have told us very clearly through Better Births and other forums that being listened to, being heard is one of the most important factors to them and can make some of the biggest differences. After that, what we say and how we say it is also extremely important. Women come into our maternity services with varying narratives of what birth means to them, how they feel about it, what stories they've been told about it, what they want for themselves and their own babies. The care that we provide them, the relationships, the communication, the continuity, the consistency, the recommendations and the evidence will all have a huge impact on that existing narrative as to how safe that woman feels, both clinically and psychologically, to give birth with us, and then ultimately what choices they will make. Tonight we'll explore the part that we as healthcare professionals play in that. And it's my pleasure to introduce our first speaker, Andrew Weeks, Professor of International Maternal Health at the University of Liverpool, who will discuss current rates of intervention in the UK in childbirth, and also give us a global and a historical perspective. Thank you, Andrew.
Thanks very much, Natalie. So let me see if I can get this to work. There we go. Is that okay? Can you see those slides okay? So thank you very much for the invitation to speak. It's a bit of a tall order, but I shall see what I can do. And this is my perspective on the whole issue. So I first of all want to present on behalf of Peter Yeh, and I'm sorry that he can't be with us tonight, but he's put together an overview of the current situation, and it's quite pertinent just to look at that first, I think. So in fact, the NHS maternity statistics came out about 3 weeks ago, and they're taken from a combination of the hospital episode statistics and maternity services data set, and they cover the last year up until March 2020. They cover all 520 births. And for those of you who are used to talking of a 600,000 births, actually you can see that the birth rate is slowly decreasing. And so the number of births here used to be up around, this is over the last decade, is gradually falling over time. Interestingly, the people who make up that number is also changing. And if you look at the age range there, look at this. This is the teenage pregnancy rate. So it's all starting from a baseline of 100. And so it's sort of standardized around there. And if you look at this, look how in the last 10 years, births in teenagers have dropped by nearly 50%. Which I think is probably good news for many, and a credit to the public health teams who have been working hard on this. The only group, in fact, who are increasing over time are the births in the 30 to 39. There's been talk of how births over 40 are increasing, but actually staying pretty stable over this time. And here we get into the nitty-gritty of it as to what sort of interventions are being done and how they're changing over time. And you can see here are the spontaneous, this is method of onset, okay? So this is how people start labor. It's not necessarily how they finish. But if you look at how people start labor, it used to be around 68% back here were starting spontaneously, and that's dropped to just around 50% now in the last 10 years. So really quite a marked change over the last 50 years. And what's the cause of it? Well, here are the inductions, and you can see how that used to be 21%, and that's now raised to 33%. And we hear stories of places where it's even higher than that. And those starting with cesarean, that is, they're having planned cesarean sections without going into labor, you can see here how it was around 12% up there, and it's coming up to around 18% there. So quite a change over the last 10 years, and that's what's provoked really this talk. How do people actually give birth? Well, the slide on the left is the main, is the sort of the overall rate here. And if you look at those delivering by cesarean section, it's now up to nearly getting on for 30% here by cesarean section, another 10–12% by instrumental, and which in fact only leaves 50, what's that, nearly 50, 55–57% as spontaneous births. And you can see how it changes over age of the woman, with increasing tendency to intervention as the ages rise. What are the most complications that people get? In fact, the most common is 41% get some kind of perineal laceration, some kind of a tear, and this covers all sorts of tears, both minor and major, but 41%, that's the most common, whereas actually this labor and birth complicated by, and I don't like this language, but fetal stress, actually that just means changes in the baby's heart rate or concerns about the baby during labor. You can see how that's the next most common one, which is 26%. Maternal care for suspected fetal problems, here we go, around 22% there. Postpartum hemorrhage, similar, and the same as other maternal diseases. So there's a lot of intervention going on out there and a lot of complications as well. What about the baby's outcome? Well, actually, if we look at the APGAR scores, the good thing from a baby's point of view is that the majority do very well. And this is the number of babies with an APGAR score. For those of you who aren't familiar, this is a measure of how well the baby transitions immediately to its own breathing, and how well it's breathing naturally on its own, how well it's adjusted. And the number, this is those with an APGAR score of under 7 at 5 minutes, for those of you who are interested in the technicalities, at 1.4% of all births. Does it affect the other things? Here we have other neonatal outcomes. Here's skin-to-skin intervention. And surprisingly, for something which I would have thought is almost universally desired, actually this is only 73% are getting skin-to-skin within 1 hour of birth. which was a figure that surprised me. Maybe I should know that, but that seems low. Whereas, of course, breastfeeding, this is their first, women's first feed is breastfeeding, and this rate is again 73% whose first feed was breast milk. But of course, there's very much an element of maternal choice here as well. So that's the overall figures. And what I want to turn to now is some kind of putting those into context, both historical and global, and to see where we stand today. How does this fit into a historical context? Now, the people will know this graph, I think, fairly well. This is the UK maternal deaths and the way in which they changed from, this is per thousand, so this is around 500 per 100,000, changed from this, and suddenly maternal mortality rates in the UK, this is all puerperal fever, Jane Eyre times, and what suddenly drops down. And there's been a lot of argument as to why this sudden decrease occurred. And you can see, compared to infant mortality, there's no sudden drop. Compared to TB deaths, no sudden drop. Why has this sudden drop occurred? There were all sorts of things that happened around that time. Remember, the NHS started just around here. There was Votes for Women came around this time as well. Antibiotics came up. So blood transfusion became available between the wars. So there was all sorts of things which came, and there's some very interesting writings on this. And Irvin Loudon, who's a medical historian, has written extensively about this. But actually, when you analyze the data, it looks really as if antibiotics were a big cause of it, improved medical care and access to it for those who ran into complications of childbirth. But what's interesting actually is that it's also related to reduced unnecessary intervention, which you may not have been aware of. Back in the 20s and 30s, there's a fascinating statistic which he comes out with, where he says that if you look at the maternal death rate by class, almost all health indices improve with social class, because you can afford access, you've got good nutrition, except for maternal mortality in the 1920s and maternal 1920s and 30s, where you've got the highest maternal mortality actually in the highest class women and the highest social class women. And that's because there was a lot of medical intervention, that there were a lot of seeing of doctors who were practicing unproven and unnecessary interventions. And what you can also see is that in places like Rochdale, they managed to really drop their maternal mortality rate in the 20s and 30s, actually, despite no changes in nutrition, in social circumstances, and actually by improving care in other ways. So it's a fascinating story, that. And I guess it brings us to the question, and you can see how in global maternal mortality, this also happens. You get a reduction in, as you provide healthcare, as you, can I get this thing? There we go. As you give more health care to people who need it, then adverse outcomes drop very rapidly initially. And a lot of us working in global health, we're working in societies where often adverse outcomes are very high, and actually it's relatively straightforward to have this initial drop. What becomes difficult then with time is actually when, as time goes on, then it gets more and more difficult, and you're running to stand still here as you're trying to get these final improvements in adverse outcomes. And in fact, the danger, of course, is that you start doing so much intervention that you start causing problems itself, and your adverse outcome rate comes up. And you can see that internationally. You can see some societies where, in fact, the adverse outcomes are rising because of over-intervention. And there's a phrase that we use in global health, comparing the area on the left, which has too little, too late, and then the right, which has too much and too soon. And there's a famous series done in The Lancet. This is going back 4 years now, all about this, if people want to read further about it. And it's quite interesting if you look, for example, at caesarean section rates. So the blue is low-income settings with very low levels of caesarean section, here around 5%, something like that, where people just don't have access to it when it's needed. Here are the high-income settings here, and the ones in the squares are the middle-income countries. And you can see how some of the middle-income countries have moved, as healthcare has become available, suddenly to high levels of intervention, and you're getting caesarean section rates. Look at this, 50, 60%, and a lot of it done in the name of trying to improve fetal outcomes. And yet, does it do that? Well, probably not. If you look at Brazil, for example, this is a famous example where they increased their rate of caesarean section. Look at this, private sector, 82% caesarean section. Public is less at 34. But you can see here how actually this is the neonatal line here, and actually really very little by way of benefit from that. So it's not a shortcut. The question, I guess, for us in the UK is, where are we on this curve? Have we started to see increase in adverse outcomes related to over-medicalisation? And certainly, if you talk of a caesarean section as an adverse outcome, then it's difficult because it's both an intervention to reduce adverse outcomes and it's an adverse outcome in itself. So the question then for us is, where are we here? And there's evidence that from a maternal point of view, we're certainly on the up here. And so if you look at postpartum hemorrhage rates, for example, those are on the rise. So, but of course, there's two people in this equation. So while mothers are increasingly having interventions, and the adverse outcome rates seem to be slowly rising, what's happening to the babies? And what we see is in perinatal mortality rate, our rate is slowly coming down. And so this is 2010. Here we've got, this is stillbirth rate, for example, just over 5, down in the last figures, just around 4. That's only one in 250. Of course, it's catastrophic for those for whom it affects. But this, increasingly, we're chasing these small number of babies who run into problems. And if it was only these adverse outcomes for the baby only occurred in high-risk groups, it would be relatively straightforward. But they don't. They occur also in low-risk women as well, which is where quite a lot of the UK intervention is coming from. And so as obstetricians, we're constantly in this, in truth, horrible battle of trying to balance maternal and fetal outcomes. How much do you intervene with women in order to try and reduce fetal outcomes? And so a lot of the intervention, which is all the discussion about electronic fetal monitoring, ultrasound, induction, these used to be just used for those people who were at high risk. But actually now we're chasing these very occasional women who appear to be at low risk and then end up in problems. And so a lot of the question then becomes, how much should these then be moved out to other groups? But of course, there's other interventions. There's not only interventions aimed at improving fetal outcomes, but there's interventions actually from the very fear of adverse fetal outcomes. And so sometimes you're intervening just in case, wouldn't it be terrible if this happened? And there's, in truth, a lot of pressure on staff, not necessarily to intervene, but to try and make sure there's no adverse outcomes. And that's as it should be. But it becomes very difficult when you need 200 interventions in order to prevent one adverse outcome. And so we're always trying to balance these two things. There's also, of course, interventions just from being in a hospital setting. And I guess these are the ones which sadden me most, where there's interventions which occur not because they're medically indicated, but because somebody's been sat in bed a long time, they're fed up, the clinicians are fed up, everyone's frustrated that things aren't happening, and it's far more difficult in that situation just to sit and wait, give it another 24 hours, we'll come back. And of course, hospitals are about treating ill health. They're not about dealing with normal physiological events. And you can see from the birthplace study where women giving birth at home in not their first pregnancy, but in subsequent pregnancies, actually had exactly the same rate of adverse fetal outcomes, but huge reductions in interventions. And so you can see how hospital itself, sometimes we don't get this right. So one of the crux of all this is how much intervention are we going to accept to improve fetal outcomes? And so if you've got a question like, and this is hypothetical, I don't want to argue over the figures, you could put whatever figures you like in here, but if you said that you could induce labour in order to reduce the risk of stillbirth from 5 in 1,000 to 1 in 1,000, the question is, would you accept that? And that's perhaps different for me, it's perhaps different for Natalie, it's different for those of you out listening to that. Some of us will say, oh, any reduction, I would take it, I would take it. And that depends on your previous exposure. If your sister had a stillbirth, for example, you would be neurotic about it and you'd want to do absolutely anything to reduce that chance. However, you might quite realistically say, so hang on, 5 in 1,000, that's 1 in 200. So you're saying 199 out of 200 are not going to get that adverse event? Why are we discussing this? This is highly unlikely to happen, and it's highly unlikely to happen. And you've got to induce vast numbers of women in order to get those occasional benefits. So these are the sort of conversations which are going on, and I don't put this question to you to demonstrate that it's because I want an answer, but almost to say, I'm not sure there is an answer to this. These are impossible choices. And but what I can say is that we need to work really hard at trying to get balanced information, both scientifically to us as practitioners, but also then conveying it over to parents so that they can make the decision. And actually, because it's an impossible question, it's almost not a medical question, it's a philosophical question. It depends on your attitude to risk. Are you one of the people who on a climbing frame is constantly crawling under your children, trying just in case they fall? Or are you one of those parents who, God, yeah, it's got dark, but go on, off you run. Let me know if you run into problems. There isn't a right or a wrong of these answers. So actually for me, it's paramount that we focus on parents' wishes. And I think we've got talks now coming up, both on the on information giving and risk, and also on how we can deal with this, and whose choice is it anyway, we'll come on to later. So that's all I wanted to say by way of introduction. Happy to take a few questions if that would be helpful.
Thank you, Andrew. I've just a reminder to everybody that we're not using the raise the hand function. So if you do have any questions, please do put them into the chat for us. So I've got, thank you for those that did send questions in beforehand as well. And while I think some people who raise their hands might want to put some questions into the chat at the moment, while they might be doing that, somebody wrote in and just asked what your views might be on how she was thinking about the medicalisation of the fetus as well. So not just in terms of perhaps the medicalisation of childbirth, but how our language and sometimes our approach to what decisions we might expect families to make about certain things that are found at Scan for Babies medicalises the baby themselves, and what your views on that might be.
In a sense, I suspect that's a slightly different question to the question that we're raising today. I know I think that what the question is about is about say fetal anomaly scanning and looking for tiny changes in the fetus and trying to work out whether that's so-called acceptable change or an unacceptable change. And I think I don't want to get into that tonight. This is a complex enough issue as it is. I have my personal views on that, and I think there is a lot of societal danger in chasing after abnormalities and somehow expecting every baby to be perfect and every one of us to be perfect, because we're all a mixture of all sorts of good and bad. And I think there's societal dangers in chasing after this perfection and not accepting people as they are. But I think that's probably a different question to tonight.
Thank you. Just some comments in our chat. That stillbirth is not the only fetal outcome that we should be considering as adverse, and that we wouldn't also do IOL just for maternal reasons as well. Oh, sorry, that we would also do induction of labour for maternal reasons as well.
Indeed, I mean it's a huge, it's a highly complex situation actually, and I think the difficulty we're in difficulties if we try and make it simple, because it's actually not simple, and actually the balance of risks. So even if you say, what are those numbers that I put up? If you chose a number, I know 1 in 500. Jim will talk a bit more about this, but if I chose a number which exemplified risk, then actually, where's that number come from? Well, it might be even a different community somewhere else in the world. It might be from data which is now 5 or 6 years old, so it's not, and actually they tend to be population data. And actually what we all want to know in this situation is, what about me? And of course it would be so easy if we said, if you did this, this bad thing will happen. If you do that, it won't happen. And that would be fabulous. But we can never say that. We're always talking in terms of these chances, 1 in 200, 1 in 100. And that's such a frustrating way to talk, because actually, if you're that one, it doesn't matter whether you're 1 in 100 or 1 in 10,000, you're the one. And it's a disaster. So it's really difficult dealing with choices. And there's a number of women who, when I speak to them, say, well, I'm very happy for you to make that choice. And in truth, I'm as good or as bad as as anyone else, I think, because I bring in my own biases. I mean, I drive fast cars. I backtrack across rural Uganda. And you might say, well, Andrew, you're a real risk taker. Why are you doing all that? And actually, because the benefits of it are great enough for me to take those risks. And so for me, I might consider myself a bit of a risk taker. And so my perception might be very different to somebody who's risk averse. And none of us have got a monopoly on the understanding here or on the truth. So I think we just need to open up that discussion and be honest that we don't actually know. And on balance, this is what we would suggest as health professionals, but ultimately it's all down to the woman as to what she wants.
Do you think that GROW or late gestation scans are increasing induction rates?
I think they probably are. The attempt to find, we know that large numbers of stillbirths are related to growth problems. And so and when you're looking on scan, you quite often see slight drops in fetal growth. And we know that if that was absolutely true, if you could get absolutely correct fetal size, then that might be a risk factor. But we also know that any scan has got its range of confidence intervals, and so it's not unusual to see slight increases or decreases. But we're very risk averse, and my guess is that many people thank us for being risk averse, but it's also others will hate us for being risk averse because it leads to over intervention.
How do we weigh up the risks of consequences of interventions, for example, second stage caesarean section and the increase in preterm birth or placental complications in subsequent pregnancies?
With great difficulty. And I think that in a sense it would be, I shall get into trouble here, but it's an awful lot easier if people just had one birth. Now, I'm not suggesting anything, I'm not recommending that, but one of the difficulties of working out birth statistics is that you've not only got to think about the birth that you're dealing with, but again, about subsequent births. And actually the first, say, caesarean section, the complication rate is really very low. But the main problem with caesarean section is not the caesarean section, but the subsequent caesarean sections. So it's always much easier if you're just dealing with the one pregnancy, but it's yet another complexity to put in the mix, is that you've got to think about, well, actually, how many subsequent pregnancies are you planning? Because actually, if you're planning 5 or 6, it's really important that we strive for a normal birth. With the first one, because you don't really want to be on your 5th or 6th caesarean section. Conversely, if you're just planning one, then it's a lot easier to talk about the various risks.
Thank you very much, Andrew. I'm going to, we've had some, I can see that there's some really great comments and discussion happening on the chat. Apologies that we can't get to all of it, but I'm keen to move us on now, because a lot of the questions also are looking at how we have some of these communications with women. I know that Jim is going to talk a little bit about that. So thank you very much, Andrew, for your presentation. And I'm just going to, I'm delighted now to welcome Jim Thornton. Jim is Professor of Obstetrics and Gynecology at University of Nottingham, and he is going to talk to us about communicating risk. Thank you, Jim.
Thank you. Thank you, Alison. And let me see if I can just share my screen. Here we go. And I just need to do that. Okay. Good evening, everybody, and thank you for inviting me to talk to you. At first, I was a bit worried when I heard the title of this session, Has Medicalisation Gone Too Far? Because I certainly don't know the answer to that. But fortunately, Andrew said, no, you don't have to tackle that one. You've got to tackle the relatively simple problem, Jim, of how to communicate risk to parents and women. And so here I am doing just that. And just a small trigger warning, I'm not going to be showing any upsetting pictures or anything, but I am going to be talking about risks. I'm going to talk about them in numeric terms. I'm going to compare them, and I'm going to talk about the risks of death of the baby. So just for warning, I hope that, because I am very much aware that we have a very diverse audience on tonight, and I know they include parents and some people who will have experienced a bad time and a bad outcome. I'm going to talk to start with about a load of stuff that you jolly well ought to know already. Kahneman and Tversky, the fellows who told us how we should be presenting risks and the problems with understanding risks, the biases that affect people. It's a very well studied area, and I'm going to tell you briefly about that. But I'm only going to have one slide on that, because if you don't know about how to present risks to patients properly and frame them both ways and all that sort of stuff, then you probably better leave this talk and go and study it, because you ought to know it. If you're going to be an obstetrician or a midwife and you're going to present risks to patients in pregnancy and in labor, we need to know how to present them properly. So that's just one slide. Then I'm going to go into the main part of my talk, and I'm going to talk about the actual risks, the evidence base for some specific risks of a number of choices which people make in pregnancy and childbirth, such things as having a free birth, a breech birth, a VBAC, things like that. And I'll run through the evidence. I won't just give you the evidence from the latest guidelines. I'll try and explain the underlying rationale behind it and some of the uncertainty. But then the main part of my talk is how to present these risks, which are complicated, in relation to other risks. The way we present risks in relation to other risks makes a tremendous difference to the way patients perceive them. And then finally, I'm going to talk about the problems that we have as intrapartum obstetricians, as an intra-labour ward midwives and people looking after care in labour, is that the task that we set ourselves presenting risk is unbelievably difficult. Andrew has alluded to some of the problems. First, there is a bit of uncertainty usually about what the actual risk is for an individual patient. What should we be comparing it with? But then the real problem is that we sometimes find ourselves having to present risks and information to women who are in pain or distracted in all sorts of ways. And sometimes, if we're unlucky, we have to present risks and information under tremendous time pressure. So that's what I'm going to talk about. Now, Kahneman and Tversky were famous fellows. 1973, they wrote their big paper, and they got the Nobel Prize for it. Actually, they didn't both get the Nobel Prize. Kahneman, Daniel Kahneman, who is still alive, he's 90 odd, he got it in 2002. But poor old Amos Tversky, he got malignant melanoma and died in his 50s. So unfortunately, you can't have the Nobel Prize after you've died. So although he was mentioned in the Nobel citation, he didn't get the prize. But Kahneman is still alive and very prolific in his 90s. And for those people who don't know what I'm talking about, he's written hundreds of books, but I think probably Thinking Fast and Slow is his most famous book. And if you don't know what I'm talking about, you might consider buying it. And they told us that we should present risks well, they told us loads of information about how to present risks and how individual people deal with risk. And we don't deal with numeric risk terribly well. And the sort of elementary things was that if you say that someone has a 2% risk of the baby dying, that sounds a great deal worse than 98% chance that the baby will survive. And yet they are both exactly the same thing. And we should, at the very least, when we present a risk, frame it both ways. And if we have time, certainly in antenatal clinics where you're talking about things, genetic counselling and screening for Downs and stuff like that, if we can put the risks pictorially, and you'll see the sort of picture I've got on the right. The problem that Kahneman and Tversky told us about was that people don't think about numbers terribly well. Instead, when they're presented with a risk, they use these heuristics: availability, representative, and anchoring. Availability is that if you can easily visualize the thing that someone's talking about, it seems much more probable, a much higher risk to you, whatever the absolute numbers are. And the obvious example of this is a woman who's had a previous stillbirth. It doesn't matter what we tell her about the risk of it happening again. To her, that risk is a very high risk. Another source of trouble is representativeness. And I've noticed a few people alluding in the chat to scanning and crossing centiles and risks of stillbirth as a result of that. And that this is one example of where we are very biased. The evidence that the growth scan crossing centiles increases the risk of the baby dying is vanishingly small. In fact, to be honest, there's probably no evidence whatsoever that actually increases the risk of stillbirth. It's immeasurably small. But it seems to a woman who sees her scan, who sees the weight of the baby going from the 50th centile down to the 20th, she thinks, oh, goodness, that's not good. If it carries on in that line, it's going to go under the bottom line and die. So a risk based on that, and the other example I've given you is altered movements. Altered movements, it seems so logical that if your movements alter, there's an increased risk of the baby dying. But the data is so small as to be practically non-existent. But we have our clinics and our ABC absolutely full of women worried about their babies for those two things. And nobody ever comes up to clinic, in my experience, because they're smoking. And yet smoking has a astronomically higher risk of stillbirth than either of those things. But smoking is not, it's not perceived as sort of when you're smoking, you don't suddenly think of the risk of, of stillbirth. And then finally, anchoring. If we have an idea what the risk should be, and then someone gives us a bit of information, we typically adjust the risk in light of the information. But the experts tell us that we very rarely adjust fully. And the example, and this is just the way human beings are. And I've got the picture of the tiger on the right, and he's there for a reason, not just because he's beautiful, but these ways of thinking stood us in very good stead throughout human evolution. When you lived in a village in India and there was a tiger who was eating people and killing people in the village, you were much more worried about it if your brother had been eaten, and that was quite sensible of you because it was available, the idea of being eaten by a tiger. If you walked around the corner and you saw anything that looked remotely like a tiger, you didn't ask questions, you ran away quick. And if you were worried about the risk of the tiger killing you, and then a hunter or somebody came along to the village and said, "Don't you worry, people, I've shot the tiger, and you can relax now. They won't. The tiger won't eat you." You would say, "Well, I will be a bit more relaxed." But you would probably, if you're sensible, be wise to not completely let your guard down, because of course the hunter might have shot the wrong tiger, or maybe there were two tigers. So we have to be a bit cautious. Now I'm going to move on to the main part of my talk. What are the actual risks? And I'm going to go through a few things, and I'm going to start with high risk things and move down to relatively lower risk. Actually, I'm not doing quite in that order. But the first one is, what if a woman comes to you and says that she would like to have a free birth? We do have data on this, and Andrew has alluded to it. The data from developing countries and war zones and things where people can't have care is not terribly reliable because so many other problems are affecting them. But there's good data from a religious group called the Faith Assembly in the 1970s. Kaunitz is the reference, and that group of people had the idea that they would avoid all medical care, just everything, antibiotics, blood transfusion, surgery. They wouldn't go and see a doctor or a nurse or a midwife or anybody. And they studied their maternal death rate, and their maternal death rate was at least as high as it was 200 years ago in England. It was roughly 1%, as high as anywhere in the world. And in the rest of Indiana, which was the state where these people lived, it was about the same as it is in the UK today. So that is very strong evidence that just walking away from all of medicine and all of midwifery and just going off and having your baby on your own, although you have 99% chance of surviving, you have a very high risk compared with the current figures of the mother dying. Perinatal death, the figures are here, 45 per thousand for the Indiana free birth people, and just under 20 per thousand in the 70s. I'm going to estimate that if you have a free birth, you have a 4 per thousand risk of the baby dying, i.e. if you have absolutely no monitoring whatsoever. It will vary a little. This particular woman who had a free birth and filmed her free birth, she had had 2 previous normal deliveries, so I think her risk was probably a little bit lower than that, but that's the risk I'm going to give you. Planned home birth, we have excellent information on that from this country and from the Netherlands, and there is a slightly increased risk. Now here I'm just talking about the baby, of adverse outcomes. These are severe adverse outcomes, not just death, but hypoxic ischemic encephalopathy and fractures, and it's 9.3 per thousand if you have a planned home birth in a low risk first pregnancy, and 5.3 per thousand if you have a planned birth in hospital, difference of 4.4%. That of course is not the difference in death, and it's actually quite difficult to get the death out because there were so few deaths, I'm pleased to say, in the study. But of the adverse outcomes in the home birth, 20% were death, and half of those we estimate would be prevented. So in very rough terms, and most of we're going to be talking orders of magnitude, 0.04% is the risk of death that you that you take if you have a planned home, this is a baby death, if you have a planned home birth for a low risk first pregnancy. Importantly, I'm not going to talk about low risk multiparous pregnancy any further, but there is no increased risk, and as Andrew alluded, much less intervention. So the place to have a baby if you are a low risk multiparous woman is at home. My daughter's pregnant at the moment, she's due in January, and I'm telling her in no uncertain terms, because I'm her father, not her carer, and I'm allowed to be directive, that she should jolly well have the baby at home. It's much safer. What about planned vaginal breech birth? Again, we've got good data from the Hannah trial, the term breech trial, which shows that of death or severe morbidity, there's about a 3.5% increased risk from the planned vaginal birth. The data on death is smaller, of course, there weren't so many, but this reference I've given you here, Burhan in the BJOG a couple of years ago, looked at all of the observational studies, the cohort studies before and after, and the planned and not planned. There's about 15 such studies, and they all show the same data as Hannah. I know someone will interrupt me and say, what about Promoter? Yes, Promoter showed no difference in the death rates, but it showed the same difference in all other adverse outcomes. Essentially, the observational data shows the same as Hannah, and the extra risk of death is about 0.3%. VBAC, well, you've got the green top guideline to go for there, 0.5% risk of uterine rupture, and rather a wonderful, I mean, the green top guideline for VBAC is very good. I didn't write it, but I think it's extremely good. And it tells you the 0.5% risk of rupture, and then it says the 4 per 10,000, so 0.04% risk of delivery-related perinatal death. And then they do what I'm going to be doing in the rest of this lecture, I hope. They put the risk in comparison. They say this is comparable to the risk for nulliparous women in labour, and indeed it is. Although, do you notice the language is just a tiny bit ambiguous? It's not completely clear whether this is an additional risk on top of the baseline risk or whether it is just the same risk. The answer, of course, is that it is an additional risk on top. I said I'd give you some slightly more up-to-date data where I could find it. And last year, the Oxford NPU and the Aberdeen group published a really wonderful study of VBAC, 28,000 from using Scottish data, but they were able to get planned data. So planned VBAC versus planned elective repeat cesarean section. And the uterine rupture risk was rather lower. It was 0.2%, the additional risk. So that's half or less than half of what the college estimated. But the intrapartum stillbirth risk of VBAC was a little higher. It was 0.06%. So bear that in mind. Some of you will be thinking, oh my goodness, he's showing us a lot of numbers. Please help us. And I'm doing it intentionally because in a minute I'm going to help you. Right, we've had VBAC and home birth and free birth. Let's have, if you're going overdue and you reach, let us say, term plus 14, what is the risk of having a stillbirth or having a perinatal death? Actually, it's the risk, as someone alluded in the chat, we should be looking at the total perinatal death rate, not just stillbirths. What is, excuse me, what is the risk from waiting a little bit longer? And the graph here is a graph which I show on pretty much all my slides, which I've stolen from Gordon Smith. The dotted line, the open dotted line, is the perinatal risk index, and that is the risk you should be looking at, not the perinatal mortality rate. The reason is that that gives you the risk per 1,000 undelivered pregnancies. So it's the risk of the baby being stillborn or dying in the first month of life, but it's per 1,000 undelivered pregnancies. And because there are relatively fewer undelivered pregnancies at advanced gestational age, the risk does indeed rise. It starts to rise at 38, 39 weeks and rises quite a bit. You know, it's rising significantly, certainly by 41 or 42 weeks. So about 5 per 1,000, if I put my marker on here, about 5 per 1,000. If we induced, we prevent everyone. But that probably isn't a fair estimate because, and we do have trials here, and the Cochrane review was updated earlier this year, and this has reviewed all the trials of induction after 37 weeks. Now you may say, oh, that's all wrong, Professor. We should be I'm interested in 42 weeks. Well, the Cochrane suggested that actually there wasn't a dramatically increased effectiveness in preventing stillbirth at the earlier gestational ages, and we can speculate why that was. I suspect it means that lower risk women went into the trials that were done at earlier gestational ages. But for what it's worth, the trials suggest 2.6 per thousand. And I think that probably is a reasonable conservative estimate, certainly for the woman who's reaching about 42 weeks. But now we come to, we've got to put all these numbers into some sort of sense. And the way to put them into sense is to present them in relation. The central square there, of course, as you all know, is the same color, but it looks different depending on how it is surrounded, what color it's shown in relation to. So let me give you the absolute attributable baby risks of death of these 5 outcomes, these 5 choices which parents, pregnant women may choose to make. Free birth 4%, and you can read the others down the planned home birth 0.04%. And I hope you'll find that helpful. Although we can argue about the finer points of exactly whether it's 0.06 or 0.05, there's 2 orders of magnitude difference, and we can learn quite a lot by we realize why relatively few women choose to have a planned vaginal breech birth, but quite a lot choose to have a vaginal birth after a cesarean section. And it certainly isn't a particularly high risk thing to do, to choose a home birth if you're a low risk in your first pregnancy. But that's not the whole story. We must do better. So let's present these risks alongside the background risk. What is the chance of your baby dying just in a completely normal low risk birth in the United Kingdom today? Well, it's not 0, and my best estimate is it's 1 in 2,800. We haven't completely abolished intrapartum stillbirths or perinatal deaths following a baby who arrives with a heart rate. So 0.036%. And that now enables us to put these risks into much better context. And that's exactly what the college guideline was saying, that the order of magnitude of a VBAC or a planned home birth in your first pregnancy is about the same. And it might be a little more, it might be a little less than just having a normal singleton cephalic birth at term in the UK. But what else do we need to put these risks in context with? What's the chance of your baby dying throughout its life? What's the chance of you dying today? What's the chance of me dying today? Well, it's about 1 in a million. That is the chance for most people of not making it through to the following day. It's a bit higher for me because I'm 66, but for almost all of the audience here, it's about 1 in a million. The risk of not making it to the next day. How do we compare these risks? The problem is that people are not very good at dealing with fractions of a decimal, as a percentage. Do you see what I mean? 96% you'll survive, your baby will survive after a free birth, and 99.9999999 your baby will live out the day. It's difficult to get a handle on how much difference these sorts of risks are. But there is a man here who has helped us, and this is David Spiegelhalter. And you'll all know David Spiegelhalter. He's one of my heroes. He didn't invent the concept of the micromort, but he has popularized it. And he is the professor of the public understanding of risk at Cambridge. And you all know him because he's the BBC's go-to man for COVID-19 risks. And he is, I'm sure you'll agree with me, he's absolutely marvelous. He's just got that way with words, and he can present risks so beautifully and carefully. I certainly, when I'm listening to the radio and somebody talks about COVID-19, I turn off unless David is speaking, and then I prick up my ears because he's able to explain things so clearly. And a micromort is a chance of 1 in a million of dying. So now we can see what the risk is of dying in a day. That's for your baby or for you in a normal life when they're living in the cot, or you're living your life at home. And it's pretty much 1 in a million. If you live for a year, it's 365. And if you have a normal vaginal birth, it's about 400 micromorts. It's not a particularly high risk, but it is, because it is concentrated in a day. So it's understandable that people do take quite a bit of care over their birthday. And here I'm going to put the whole thing in a graphical picture from a paper that Kate Walker and I wrote a few years ago. So this graph shows us the risk of dying every day, and for most of us it's so low you can't even see it on the graph, but it's 1. Here's me at 66. It's getting measurable. It's a bit worrying. I might not make it through till tomorrow. But the birthday, so for ignore this dot, that's the risk of being born in the United States, a very dangerous country. This is the risk of being born in the United Kingdom, 400 micromorts. And if you decide to have a home birth in your first pregnancy, you push that up to 800. If you go overdue more than a couple of weeks, you're probably pushing it up to 1,000. If you have a planned vaginal breech birth, you're probably pushing 3,000. And if you are foolish enough to have a free birth, you're way off the scale. Now, that's more or less all I'm going to say about these relatively well-defined risks. I'm now going to just have a few slides before I finish to talk about some of the risks that we have to discuss with women, with mothers, in labour. Difficult time because of the urgency of making decision and the woman being in pain. And I want to make one comment. Andrew said that dealing with risk was very difficult, and it is difficult. I don't for one moment doubt that, but in some ways it is easy. The person who makes the decision is the mother. It is absolutely the mother. There is no possibility of us overriding her, even for the things on the screen at the moment. For us to do those things without her informed consent is a serious assault, and even more so to do a cesarean section or to induce labor or anything at all. The mother's wishes, the mother's consent is absolutely paramount for all of these risks. She can weigh up the risks to her and the risks to the baby. We don't weigh up the risks to her and the risks to the baby. And so that sort of makes it easier, but it doesn't make it easier, because we then have to present those risks in ways in which the mother can understand, and that can be difficult. So let's just think about what sort of risks we are asking women to take if they decline, let us say, a vaginal examination in labour. Well, I don't know. I don't have those numbers. I've never read a paper that says what those numbers are, but I've got an opinion. And I think if you're in spontaneous labour and the fetal heart rate is normal, and you say, I don't want to have a VE now, I'd like to wait another 4 hours or 6 hours or 8 hours, I don't think there's any risk at all. I don't think there's a single, it's certainly unmeasurable. And it's ridiculous to say that woman is putting her baby at risk because she has declined a vaginal examination. However, let us imagine another woman who has a prolonged bradycardia, and the fetal heart is down and it's staying down, and the obstetrician or the midwife want to examine her because they want to get some information. They would like to know whether the cord has prolapsed. They would like to know if she's fully dilated, and it might be wise to do an instrumental delivery or whatever. Well, I don't know what the risk of her declining the examination would be for the baby, but it's still not going to be very high. We would regard it as a very high risk in that situation, but in absolute terms, 1%. Most people don't have cord prolapses. If they prolapse in full dilatation, the baby usually delivers, and most bradycardias recover. What's the actual chance? It's not going to be very far off 1% in my humble opinion.
Jim, sorry to interrupt, just to give you a 2-minute time check.
I've got 2 slides, so I'm good to go. Here's a woman who wonders if she needs to have an episiotomy. What's the risk of her having a third-degree test? 0. What's the risk with a prolonged bradycardia? Well, I've talked about that. Same thing. There might be 1% if we're very unlucky. And then we have a rectal examination after birth, which some people are wanting to advocate for everybody who has a perineal tear. It strikes me that is there is a risk, and it's not 0 because there is a risk of missing a sphincter tear and a buttonhole tear, and somewhere between 0 and 5%. But after a normal birth with an intact perineum, it is absolutely 0. How do we deal with these problems? Well, if there's pain, we need to sort out the pain first and come back to help the woman once the pain is sorted. That doesn't help for some of the decisions where the decision is what sort of pain relief to have. But in those situations, we do our best. And we remember that parents and women can follow other decision-making strategies. And a very good and acceptable one is to ask their friend, ask their birth partner or a doula, what do you think? And hopefully the doula knows them well enough to know their attitudes. It's perfectly acceptable for a patient to say, I'll have the usual. I'll have the usual. Lots of us face complicated decisions, and we recognize that there is a midwife or an obstetrician who's much more expert in the issue than us, and we're happy to hand it over to them. And there's nothing wrong with that, but the patient has to make that decision. And the same sort of thing is letting the doctor or the midwife decide. It's wrong for the doctor or the midwife to decide, but if the patient says, oh no, you decide, I can't make up my mind, that is a perfectly reasonable thing to do. I've finished. Thank you for listening.
Thank you very much, Jim. We haven't got too much time for questions, but I just wanted to get your thoughts on something posed in the chat. Should we be consenting women for hospital birth if the risks are so much greater? And the same with CTG, poor evidence, yet known increased risk of C-section. Do we tell women this?
Well, I think for hospital birth for a multips, if you've had a perfectly normal birth in your first pregnancy, like my daughter, I do, yes. It just, I can't get over the fact that, I mean, we do, I think, offer home births to people. I hope we do. We tell everybody that we do. I think we do in Nottingham. But I'm not sure that we explain to people that actually you are absolutely as safe and you will have significantly less interventions if you're in your second or subsequent pregnancy. The business of electronic fetal monitoring, I don't want to go in there because, yes, the trials don't show a difference in perinatal mortality. There are some observational studies that show that you might save about 1 in 1,000. And you're quite right, electronic fetal monitoring does increase the risk of cesarean section. So women should definitely be informed of that and prior to having the belts strapped on.
Thank you. We may get some time to come back to a couple of those questions, and we've definitely got some really interesting chats going on about considering women who don't have English as their first language and how we support communication with women like that, and also some questions around, there was a lot of information there about risks to babies, but a little bit more about maybe the women themselves. But I'm just going to move us on. Thank you very much, Jim, for your presentation, and if we've got any time I'll come back to some questions. But it's my pleasure to introduce Maria Booker to you now. Maria is Programme Director for the charity Birthrights, the UK charity dedicated to improving maternity care through a focus on human rights. Maria leads the charity's policy and legal work, and also birthrights training of healthcare professionals and peer supporters. Thank you, Maria.
Good evening, and thank you very much for inviting me to join this very interesting discussion this evening. As Natalie said, I'm Programmes Director for the charity Birthrights. So anybody who's not familiar with Birthrights, we're a charity dedicated to improving women's experience of pregnancy and childbirth by focusing on human rights. So I've been asked to talk this evening about who gets to decide what risks are acceptable to the person giving birth and her baby. And in some ways this is quite an easy task because the law is very clear. We tend to talk about having two sources of human rights law in our work. So the first source is the European Convention of Human Rights, which is incorporated into our domestic law via the Human Rights Act. And that in itself would provide protection for women to exercise their autonomy and to choose the circumstances of their birth. But in the UK, we also have a very rich source of common law, which has a very strong tradition of protecting every individual's rights to make their own choices, but particularly a pregnant woman's right as much as anybody else. So I'm just going to share with you a couple of cases that have really formed the foundation for this in our common law. The first goes back right the way to 1997. The case is MB, and this case was about a woman whose baby was in the breech position, and she had consented to having a caesarean section, but she also had a phobia of needles. So when she was taken to theatre, she in practice refused to have the anaesthetic, and so the health authority applied to the High Court in order to get a declaration to dispense with the need for her consent if that was necessary. And this was a really formative judgment because the Court of Appeal, who looked at this case, said the following: a competent woman who has the capacity to decide may, for religious reasons, put my finger away. A competent woman who has the capacity to decide may, for religious reasons, other reasons, for rational or irrational reasons, or for no reason at all, choose not to have medical intervention, even though the consequence may be the death or serious handicap of the child she bears, or her own death. So as you can see, that judgment pulled no punches about the rights of an individual woman to decide what should happen to her body, even when she was pregnant. And the court recognised that sometimes temporary factors could interfere with the capacity to make that decision, as it did in this case. But the fundamental principle here was that every woman should have the right to decide what happened to her body, even in pregnancy. It's worth noting that the woman went on to consent voluntarily to the caesarean after someone had the bright idea to give the anaesthetic without using a needle, which I think shows that healthcare professionals have very good ability to be creative and respond innovatively when they need to. So this case was followed the following year by another case called S versus St George's Healthcare Trust. Now this case involved a woman who had severe preeclampsia, but she also had moderate depression. But in terms of her preeclampsia, she was advised to be induced, and she declined that induction. She was then sectioned under the Mental Health Act against her will for assessment, and then transferred to St George's, where the trust applied again to the court for a declaration that would enable them to dispense with her consent if they needed to do so. And the judge did grant the declaration, and the baby was born by caesarean section, and the woman S was taken back to the mental hospital and discharged herself after 2 days. The court said that the trust had failed to distinguish between her urgent need for medical treatment and whether her depression warranted being detained. So again, this was a very conclusive judgment which said In our judgment, while pregnancy increases the personal responsibilities of a woman, it does not diminish her entitlement to decide whether or not to undergo medical treatment. Although human, an unborn child is not a separate person from its mother. Its need for medical assistance does not prevail over her rights. She is entitled not to be forced to submit to an invasion of her body against her will, whether her own life or that of her unborn child depends on it. Her right is not reduced or diminished merely because her decision to exercise it may appear morally repugnant. So as we can see, the UK courts have been extremely clear about a woman's rights to decide. And of course, couldn't pass up the opportunity to mention Montgomery versus Lanarkshire, another landmark case in terms of a woman's right to choose, or any patient's right to choose. So I'm sure this case will be familiar to most of you, but just to recap, Nadine Montgomery, who we're very lucky to have as our patron, was a diabetic woman of short stature. She was concerned about her ability to give birth vaginally to her baby, and her obstetrician kept reassuring her that it would be fine. Nadine Montgomery kept raising the option of a cesarean, but she was reassured and told that it would all be fine. In the end, her baby got stuck, so she had a shoulder dystocia, and her baby Sam was born with cerebral palsy, and Nadine herself suffered quite extensive damage. So the reason this is such a landmark case is because it changed the test for consent in the courts. So prior to that court case, the standard for consent was treated exactly the same as the standard for negligence. So it's what we call the Bolam test. It meant that the court would look at whether other doctors would have made the same decisions or given the same information in the same circumstance. And if a doctor could show that other doctors would have done the same thing, then the court would rule that that doctor had not breached their duty of care to that patient. Whereas after the decision, we now have a twofold standard for consent. The first limb of the test is that what risks associated with an intervention were or should have been known to the medical profession in question, and that remains something that's judged by the standards of the medical profession. But the second limb of the consent test now is when the court is looking at what risks should have been disclosed, they are going to look at whether those risks were material. And the test for whether a risk is material is one to which a reasonable patient would attach significance, or whether doctor is or should be aware that this particular patient would attach significance to it. So it's no longer a test that's judged by the standards of the medical profession. It's a subjective test that's going to be judged by the courts. And whilst Montgomery versus Lanarkshire is known as a landmark test about consent, I think Lauren Sutherland, who is one of the barristers in the case, sums it up very well here. The main point about Montgomery versus Lanarkshire is it's a case about a patient's right to choose, or a woman's right to choose in maternity services. It's a right to be informed of the reasonable options for treatment, and for healthcare professionals to support that woman or that individual giving birth to be in a position for them to make the right decision for them. So, as I said, the law is crystal clear about who gets to decide what risks are acceptable to the mother and child. It's always the person giving birth, as Jim has already said. So is this what happens in practice? Jackie Nichols and her team at UCL have done some research about what this process looks like in practice. So it was a small study they did. They talked to 16 pregnant women and 15 healthcare professionals. But what they found was very rich. They really followed every appointment these pregnant women went to, and tried to look at whether Montgomery versus Lanarkshire was alive and well in practice, or whether it was still something that was theoretical. And these were some of their main findings. They found that the context of disclosure was really important. So where women had a really good relationship with the healthcare professional, they asked less questions. They were less interested in the volume of information. They trusted the information that was given, and vice versa. So where they didn't know a healthcare professional very well, or there wasn't that trust there, asking questions and asking for more information was a proxy for that trust. They also found that what women wanted to know was how information applied to them. The women they talked to talked about being overwhelmed by the amount of information, but what they wanted to know was the individualised information, how it was relevant to their particular circumstance. And this is what healthcare professionals found hard to give. They also found that there was still a lack of awareness about Montgomery itself, and particularly amongst midwives, but amongst doctors as well, and the implications of the case for the care that they were offering. But I think this last point is the most resonant for me, in that the pregnant women that they followed didn't always experience consent as a choice. They experienced what they called expected compliance. And I think that's a very descriptive phrase of what women who approach birth rights tell us of their experience. Birth Rights also did a survey with Mumsnet earlier this year. It was due to coincide with the 5th anniversary of the Montgomery versus Lanarkshire case. And again, the survey was designed to test how far women were experiencing the antenatal choice process, and how far that reflected the legal reality as set out in Montgomery versus Lanarkshire. And the results were quite worrying. So 14% of those who were surveyed said that their opinions and decisions were overruled, and a further 11% said there was an attempt to overrule them. 24%, so nearly a quarter of those surveyed, said that their decisions and opinions were not respected, and 30% said that their decisions and opinions were not sought at all. And finally, the survey set out an outline of the legal position, i.e. that an expectant mother is the primary decision maker about her care, and the midwife and doctor's role is to advise her. And the women were asked if it reflected their own experience. Less than half, 45%, felt it did reflect their experience, and 42% said it did not. So whilst the law is clear, I think the more difficult question to answer is why there's a gap between the law as it stands and what many women still experience in maternity services in 2020. And I'm very interested to hear the views of those listening to what the answer is to this. So here are a few theories. The first is that perhaps there isn't enough awareness of this legal framework. So this study by Sue Krusker et al. Was conducted in Australia. So Australia has a very similar legal system to the UK in terms of the legal obligations of healthcare professionals. And this study was very interesting because it asked midwives and doctors in Australia whether they believe the final decision should rest with the woman. And a majority of the healthcare professionals they spoke to said that it should. But they also asked if those healthcare professionals believed that the needs of the woman should sometimes be overridden for the safety of the fetus. And a majority said yes. And of course, it's not possible to hold those two beliefs simultaneously. They're contradictory beliefs. And Krusker put forward, the following explanation. She said that doctors believe themselves to be ultimately legally accountable for outcomes experienced in pregnancy and birth, despite the legal position that all healthcare professionals are responsible only for adverse outcomes caused by their own negligent outcomes. So there's certainly something about legal understanding and also fear of what the consequences might be of a bad outcome. Another theory is that perhaps, even if coming from a very well-intentioned place, doctors and healthcare professionals perhaps feel that they have a better understanding of what the risks are and a better knowledge in some cases, or perhaps that there's pressure on them, as Andrew alluded to avoid any adverse outcomes for the baby in particular, which certainly seems to be a theme of the policy environment at the moment. But Andrew Kataska, who's a Canadian obstetrician, put forward this rebuttal in Birth in 2017, where he dismisses the right of doctors to feel that way. He says some suggest a woman has an ethical duty to her fetus that limits her autonomy and implies that physicians have a moral obligation or an authority to enforce this duty if a woman neglects it. This stance is paternalistic, condescending, and without ethical or legal basis. Even when based on best evidence, a clinician's estimate of harm versus benefit is imprecise and not infrequently wrong. Since reasonable risk and expected benefit are subjective, a clinician's belief about what constitutes neglect is an opinion based on the clinician's rather than the patient's views. Neither medical professionals nor the state have ethical or legal authority over a woman based on the presumption that they care more for her fetus than she does. And I think Kataska reminds us that there are always a number of factors that go into a woman's decision, and only some of them are to do with clinical evidence. And in any case, we should be careful about the amount of confidence we can put in that clinical evidence. So we know that that evidence will factor into a decision, the research basis we have, the NICE guidelines, but a healthcare professional is also going to bring their own experience. For better or worse, sometimes, you know, that can be very helpful, but in some cases, if they've had a bad experience of a particular type of birth or a particular outcome, that can overshadow their advice and their interactions with a woman in a particular situation as well. And also the healthcare professional can never know what the woman is thinking, her own values, anything that she is bringing to the birth as well. She may reveal some of that, but there may be some of that always remains under the surface. And both parties will bring in unconscious bias as well, that's shaped by their own upbringing, their culture, the media. So we must bear in mind that a decision always goes so much wider than just clinical factors. So one of the things that I'm going to leave you with tonight is to urge all the healthcare professionals who may be listening to reflect on how they feel about the law and what it means for their practice and how they feel about it. Because I think where healthcare professionals haven't always come to terms with that, we can see a number of ways where they try, in some circumstances, to go round it. And these are three that I've noted that I've come across in my work at Birthrights. So the first one is that you can sometimes hear reports of consultants or other senior members of staff saying, well, if the individual has not accepted the recommendation, it must be because that healthcare professional hasn't told them right. If they presented it in the right way, if they gave the right facts, if they put the right emphasis on the right things, then, you know, the individual couldn't possibly have come to that decision. Which of course, you know, isn't true, and often results in a woman kind of receiving, you know, 2 or 3 consultations from different healthcare professionals, which, when taken cumulatively, can feel quite coercive. Another trap that I think healthcare professionals can fall into is thinking that if an individual hasn't accepted the recommended course of action, that they're a bad mother, so that they're, you know, they might be at risk of harming their baby. I just recently dealt with a case that came to Birthrights of a woman who wanted to have a home birth, and she was advised that her baby might have a health condition when it was born, but the woman did a lot of research about the particular health condition and ascertained that the baby was unlikely to be born in a poor condition. If there were any issues, they wouldn't emerge for sort of 24 to 48 hours at a minimum, and it was likely that they might not emerge for weeks or months. And in any case, the diagnosis was not definite in the first place. So this woman was very keen to have a home birth, and the head of midwifery signed that off. But the paediatrician involved felt that went against common sense. And the woman asked if he could present some evidence for that, and he was unable to do so. But because he felt that this was the wrong thing to do, he referred this woman to social services, not only for her baby, but for her other child as well. And of course, that's a completely unacceptable way of using a social services referral, which is always around whether there's a risk of significant harm to the baby once the baby is born. But can be a way of getting around the discomfort with a decision that isn't in line with the healthcare professional's own choices or own values. And finally, something I think we're seeing more of is that when an individual disagrees with a recommendation, they're sometimes felt to lack capacity, and therefore a capacity assessment is arranged. And again, ironically, when there are individuals who may well have capacity issues, but they're agreeing with the recommendations that are being put forward, their capacity is less scrutinised. But when women are going against the recommended course of action, there is a lot more scrutiny of their capacity to make a decision. So I just wanted to highlight those, potential elephant traps. I'm sure that many of you on the call would not sort of fall down these, but I think they are ones that we see evidence of in our work, which are quite concerning. So what can you do as an individual to make sure that you are practicing in line with the law? Again, I would just urge you as a healthcare professional to reflect about how you feel about the law, because it's not easy. The ultimate consequence of upholding a woman's autonomy can be very difficult, and I think it's important that we acknowledge that. But the opposite is worse, and is likely to cause significant harm as well. So it's important to take time to reflect on that. Andrew mentioned at the beginning about listening to women. I think that's the most important thing you can do. We know that's what women value most of all, feeling they're being listened to. And then there's the opportunity to reflect on the language you use as well. Does it promote choice and autonomy? And I think those are individual actions, and we often talk about healthcare professionals improving their own practice, and that's really important. But individuals experience maternity services as a whole, and I think the next stage is to look at how individuals coming into an individual maternity service might feel, and being prepared to challenge other colleagues or the policy setup if it doesn't fit with where you would like to be and where the law says that maternity services should be. So I hope that's left you with a few thoughts about where to go from here. But thank you very much, and very happy to take some questions.
Thank you so much, Maria. Extremely thought-provoking, and just hearing your survey results clearly have some work still to do, as we know. I'm sorry that we don't have all the time to have the full discussions that are happening on the chat, but I hope all of you watching tonight are able to engage with the chat, because there's some really great conversations and discussion happening on there. Just wanted to read out, Maria, just a couple of comments from one of our colleagues. Good point about applying information to specific women, Maria. It seems to me that this should be the case for many risks that are currently framed as standard. The risks in RCTs may not be the same as those women will encounter in their local hospital or maternity care system. We know from the NMPA data that there is great variation in intervention rates, controlled for case mix, and these are not obviously linked to differences in adverse outcomes. So population level data on, for example, the risk of complications during birth as measured by rates of interventions has to be contextualised by local hospital practices and norms, as this is what women will actually encounter in real life. And then just to go on to say that it is of course important that the right and autonomy to make decisions also implies responsibility, just as parental decisions about the way they parent after birth also implies responsibility, that they will make the best decisions they can in the circumstances in which they are. These decisions usually turn out well, but not always. That is a consequence of being an autonomous human being, and birth is not different, surely.
Yeah, I completely agree. I think that's the other side of the equation, and that was recognised in the Montgomery versus Lanarkshire case. Women, it's about treating women as grown-ups who are prepared to make decisions and take responsibility for their choices. That was specifically what the judgment said, and I think that's absolutely right. Women have to accept that responsibility, and healthcare professionals need to step back and let them have that responsibility too.
Thank you. Apologies if I dropped out there. I think it's my signal. Just very quickly before we move on, there's a couple of comments around use of language, and as you just say in that last slide there, thinking about the words that we even use when we talk to women can seem inconsequential to us, but even changing things like the word risk for chance, and the way in particularly we talk about labour in terms of, you know, delay in labour, rather than using words like failure. All these things around language and the actual specific words we use also really important in helping to engage with the women really well. Thank you so much for your time, Maria. If we do get any time at the end, we can come back to any other questions as well, but thank you very much.
No problem at all. Thank you.
I am really delighted to move us on to our last speaker of the evening, Kemi Johnson. Thank you so much, Kemi, for joining us when Miliha was unable to at such short notice. Kemi is an independent midwife and activist. Kemi, over to you.
Thank you. Just as I share my screen. Share. Almost the slideshow. There you go. Can you see me clearly? I hope you can.
Kemi, we can see really clearly, but I might need you to just speak up just a little bit if you can.
Yeah, I can do that. I can do that. I've got a lovely loud voice. I feel really, I'm excited to be part of this panel tonight, and I've just heard such excellent presentations, and I've been writing down lots of questions myself, and hopefully we'll get a time towards the end to hear some of the amazing questions that I've seen in the chat as well. So just need to, I wanted to start with this slide, this is important to me as a birth keeper, a midwife, formerly a midwife, and a birth keeper and an activist. The way I move in this space of assisting families with birth is always, you know, these questions that I've got here, you know, whose risk is it? Whose baby is it? Whose body is it? Whose mental health is it? Whose relationship is affected by what happens around birth? Whose career is affected by it? I've seen some amazing effects. I've seen people move from their careers into birth work. They become doulas and midwives and activists. I've seen that, positive changes. Whose genitals are they anyway? That's an important one. They're all important, but in particular, things happen to women sometimes at that moment of birth that they may have put in their birth plan they didn't want, they may have expressed that they don't want, but then there's a sense of urgency put into the situation. And some women do say that they feel coerced at that point, that they feel that their control has been taken away, that they don't have their freedom to choose. Their freedom to choose is suddenly denied in favour of the baby that they're carrying and giving birth to. And whose life is it anyway? So these are the questions always at the back of my mind when I'm helping families. So this is the kind of scene I'm used to seeing, because I usually attend births at home. And here we've got complete intimacy. The woman's meeting her baby. Can you imagine the feelings, those of us that actually have been through this ourselves and have had what we feel is a victorious birth, a birth that we could feel proud of, a birth where we felt in control and where we felt honoured and respected. And she's got her partner, who I presume is a partner, leaning right over her. And that's just such a respectful, honouring, sacred moment. And that's the kind of birth that I tend to see. And this quote, so there's some parts of this slide are quite reedy, but I just think the words are so important. So birth is an opportunity to transcend, to rise above what we are accustomed to to reach deeper inside ourselves than we are familiar with, and to see not only what we are truly made of, but the strength we can access in and through birth, by Marcy Macari. And this was brought to my attention by amazing birthkeeper photographer, Hannah Palamara. So I saw this on her Instagram and asked permission to share it because I just think it's so important, and it perfectly expresses what I see in the families that I support. So the question that Millie was going to tackle, supporting those not wanting intervention, what does that look like from a consumer perspective? So I think I was a really good choice of Millie's to share this, because all I had to do was go back to the families that I've served and find out, what does that look like from a consumer perspective? Someone who doesn't want intervention, someone that believes in their ability to birth, that looks back through history. And in particular, there was a slide that was shared where the y-axis was so disproportionate. So it showed the change in maternal mortality throughout centuries, but it showed that the y-axis was really exaggerated. So the difference was really exaggerated. You know, just to move on, what does that look like from a consumer perspective? Because we always got to think about how we share, what we're sharing, what we're aiming to achieve. All I aim to achieve is to give information. Sometimes it's advising, but it's usually information with which the parents can make informed decisions, particularly the birthing parent. So I just want to share with you some of the comments I got back from the parents I asked, the birthing parent. We wanted to know what all our options were and the evidence that supported each of them, so we could make an informed choice. You're going to see there's themes that repeat through what I'm going to share. We were looking for individualised patient-centred care and to not be coerced into routine care driven by policy. When talking with parents, often they find that they're coming up against coercive language, the use of the word risk or high risk, but not actually sharing stats. So again, they're not being informed, so they can't really make an informed choice because they've been given emotive language rather than given the actual facts. And I know the facts are difficult to deduce sometimes. The use of RCTs are not always appropriate. You know, some things haven't been studied because, you know, there's just not been sufficient interest or funding for that particular area of study. But still, we've got to do our best, at least provide some figures. Another comment, this is in two parts, from another mother. For my second baby, I wanted an undisturbed pregnancy as much as I wanted an undisturbed birth. And I'll elaborate there. Because of her first experience, she was very resistant to most things that we would consider routine or standard in antenatal care. So she sought to not have any blood work. She didn't want any blood work, and she didn't want any scans. And she didn't want to be routinely have her blood pressure checked and her urine checked. She didn't want to routinely listen to the baby. So she was doing a lot of choosing for this second baby as a result of trauma from the first pregnancy, where glucose was being measured, blood pressure was being measured, and there were lots of choices taken away from her because of the figures. So she just unchose that for the second time. And that needed to be respected and not feared, because at the end of the day, she was an intelligent adult making her choices, and it was her body. So she said, I needed someone by my side who would encourage and support my choices and give me the confidence in my ability to birth naturally. That's what she really needed for her second pregnancy, because she had an inkling that it might help her heal her experiences from the first pregnancy. And she goes on, I found that very person in an experienced, caring, confident and nurturing I am. She was my sole caregiver throughout my pregnancy and birth. I went on to have a very quick and beautiful home birth. Compare that to my first baby's hospital birth of 27 hours with numerous unwanted interventions. which left both my husband and I traumatised. The recent birth of our second baby is a help to heal the painful experience of baby number one's arrival, which of course most of us, you know, my colleagues here in my hearing will know that hers was an induced labour. I got a comment from another mother, just keeping an eye on my time. She says, as a parent, so that she was answering the question, she said what it looked like to receive that kind of respectful care was being listened to, being centred in my pregnancy and treated as a unique individual, being involved and in charge of all decisions around my baby and body, building a trusting, continuous relationship with our care provider. So you can see the themes that are coming out again. Most parents seem to want the same thing or similar things. Being informed, educated, and ultimately having a happier, healthier postpartum. All of which was especially crucial being a parent who is officially disabled, or as I prefer, differently abled. And the immediate assumption is someone like me needs intervention. So yeah, there was a lot of assumptions made at the beginning of a second pregnancy about the kind of care that ought to have been offered and the kind of care that she should be seeking. And we have to look at this, you know, at the end of the day, whose risk is it anyway? You know, she was told lots of scary things, and in the end she found someone who just listened and was able to walk this journey with her, respecting her choices and having faith and trust in the process and knowing that they've got the skill set to help if help was needed. And that changed her world. It absolutely changed her world. She's now an on-fire birth activist and birth keeper for others. Another comment from another mother. I was lucky enough to give birth with the rarest kind of birth keeper. She held a space where I truly met myself and welcomed my baby uninterrupted, the rarest gift. I didn't have the burden of being told I was irresponsible because my baby was late. I was listened to. I wasn't not allowed to wait for my contractions to progress. I was helped to relax. Instead, you know, that can help contractions to progress too. I wasn't told when to push. I was held as my body led the way. I wasn't delivered of my baby. I was encouraged to move into a position so I could catch her myself. At the heart of this was my midwife birth keeper who held a space for the mother, baby dyad, to lead and not be led. She had taken the time to get to know me, over 20 hours together. At difficult moments, instead of buckling under the pressure of potential culpability, should things go wrong, she used her incredible skill to tune in rather than intervene. When a moment of self-doubt crept in during transition, she asked, "Would you like to hear your baby?" That heartbeat, beating strong, was enough, and she knew it. My connection with my body and my baby was the light that led the way, not the stats or what ifs. A healthy baby born in water at home, surrounded by love, neither one of us touched. Sadly, a million miles away from what my friends have described. One of the greatest sadnesses of unnecessarily medicalised birth is that women blame their bodies. My birth keeper enabled me to trust in mine, and realising that trust and connection with myself is something that has changed me forever. So the women blaming their bodies, you know, we're quite quick to blame ourselves for things, but I get reports back from women that seek me for birth afterthoughts that say that they were blamed by their clinicians. They'll be, "Oh, knew you shouldn't have carried your baby to 42 weeks. Now your baby's so big that you have to have a cesarean," and things along those lines. And that's what many women are experiencing. Again, this amazing paper 4 years ago by Miller et al. In the Lancet, Beyond Too Little, Too Late, and Too Much, Too Soon. So we have the too much too soon problem, and I really respect my colleagues who pointed that out in earlier presentations. We're getting that incline, you know, that where we're heading in the wrong direction with regard to outcomes, particularly postpartum hemorrhage. And in this paper, there was a couple of paragraphs that stood out for me too. Too much too soon describes the routine over-medicalisation of normal pregnancy and birth. Too much too soon includes unnecessary use of non-evidence-based interventions. And we know, those of us that are in this hearing, we know what they are. As well as use of interventions that can be life-saving when used appropriately, but harmful when applied routinely or overused. As fertility births increase, so does the recognition that too much too soon causes harm and increases health costs, and often concentrates disrespect and abuse, which I know all of us that went into birth care, we don't want to be tolerating that the people that we're caring for are suffering disrespect and abuse. That's intolerable. Another paragraph. Healthcare providers and health systems need to ensure that all women receive high quality, evidence-based, equitable and respectful care. I'd also need to add in there physiological knowledge, that those of us that are working with families, that we understand how birth actually works. It also says the right amount of care needs to be offered at the right time and delivered in a manner that respects, protects and promotes human rights. So of course, this picture, I don't know if it's over the top really. I'm not very often in these kinds of environments, but when I'm in birth afterthought sessions and women are sharing what happened if they have a birth that resembles this one, what they say is that they imagine, you know, that they can't see these people's faces. They can only see their eyes. They imagine that they might be bumping into them in the street because most of them go to their local units. So they could be bumping into them when they're shopping at supermarkets or when the doctor's surgery, but they don't know because they can't see the rest of their faces. They're wondering how many people have seen their genitals. You know, she couldn't even see them, but everyone else can, and they're all staring at them. She's in a submissive position. She's on her back with her legs open in lithotomy position. So there's nothing she could do. Even if she wanted to stop something, she's powerless to do anything. So this is not the picture of respect. This does not resemble what most people dream of when they're thinking about meeting their new person for the first time, their new little one. And then I shared this on my Instagram because it made me cry a lot. And I always think that it's important that parents feel heard. And so she sent it to me, so I shared it on my Instagram. And it resonated sadly with many parents. And I'll read this to you as well, because every word is important. On my second night of being sat in the induction ward, not being induced and not in labour, they brought in a woman with her partner and mum. She was so loud. I remember rolling my eyes that it was 9:30 and yet another woman in active labour was going to keep me up all night. I heard them tell you, so she starts referring to the woman, I heard them tell you to let them examine you, and you refused 4 times in 20 minutes. I heard you tell them you were in labour and wanted to go to the birth centre as you planned, and then tell you that if you didn't let them examine you, then you weren't going anywhere. I heard them tell your partner and mum to leave as visiting was over, and you grabbed your belongings and you say you weren't staying there without them. I heard them ring the birth centre and tell them that they're dealing with a difficult patient who's going home if she can't go there with her birthing partners. I heard you crumble and cave and allow them inside of you to find out you were only 3 centimetres. So you weren't in labour and weren't going to the birth centre until you measured 4 centimetres. I heard your partner standing his ground next to you, refusing to leave your side, but your mother bullied into leaving. I heard them tell you that because you'd been admitted to the induction ward, you were no longer allowed in the birth centre and were taken to the labour ward. The next morning, I heard the midwives laughing about the woman who wasn't even in labour, who was sent to the labour ward and ended up with a C-section delivery. Now, these are my thoughts, kind of condensed into one sentence. It was a ranty sentence. Gosh, I'm not sure how many years ago now when I said it, but it is doing the rounds on social media around the world. I get it posted to me from South Africa sometimes as well, Australia. Childbirth should be a natural event that occasionally needs medical help, instead of being a medical event that occasionally happens naturally. And I really think that if we start to consider that as a reality, and it really is, because many of us would give birth without any kind of medical assistance whatsoever, because it's part of the design. And then the medical assistance that is required can be kept for those that really, really need it. Rather than dismantling the confidence of a woman and her supporters throughout the pregnancy to the point where she just hands her body over and says, what would you do? Oh, I'll just do what you say. At the end of the day, it's not a medical event that always needs medical assistance or medical advice. And I think if we started to think like that, we'd more easily be able to resist seeking compliant parents or coercing them into doing what we feel comfortable. I know we've got the issue of litigation to consider, but in all honesty, from what we've heard from Maria Booker tonight, I think we all need to start looking again at what our standing is, our understanding is of the legal standpoint of the clinician in the birth setting. I think we really need to work with that, think about that, think about the way we communicate, listen more, trust more, respect more. And I think that's the way we can start to really find that balance when we're talking about the words chance or risk or outcomes. Ultimately, it is the woman's choice. The baby is inside of her body, and she's really the only one that's having the risks. She and her child are the ones that bear the risks. We need to respect that and honour that. And those are my thoughts. And those are the thoughts of the parents that I asked for some feedback on what their experience was of not being intervened with and being listened to. So I hope that's been helpful.
Thank you very much, Kemi. Lots of lovely comments about the privilege of hearing such powerful birth stories and experiences of giving birth from those women. Question from someone of our audience. Thinking about the differently abled mother, similar assumptions can also be made about women who are considered low risk, but who want to plan a caesarean birth or choose other intervention. Their intervention can be deemed unnecessary, and it's important that all women and all choices are treated with respect and support. How do we support those women who may choose intervention?
100%. What an amazing question. I go along with their choice. It's their body, it's their choice. And I give them some suggestions about how they can have a gentle caesarean, how they can have a woman-centered one, how they can promote the health of their child with regard to the microbiome, or with regard to them getting their full blood complement. So once they've chosen what they've chosen, then I help them have the best one. And they can approach their choice with joy and power and stay in control.
Absolutely. Thank you. When we consider the small number of women who may need medical intervention, some of the questions and thoughts from our audience are around, if you don't do some of the recommended routine practices that we have, how is it that you can know which are going to be those women that may need the intervention?
Really good question again. There aren't many women that resist that. you understand that was a trauma response. And now that she's had a healing birth, the next time she may be more trusting of the caregiver and say, yeah, I know you're not going to freak out if my blood pressure's on the high side. I know you won't freak out if there's sugar in my urine. So there'll be more trust. So she will choose differently. It's not often that you come across a woman that unchooses like that. And I just knew part of her healing, it was mentioned in another bit of feedback, that I didn't let my culpability stamp all over her rights to choose. So you document and you flow with her and you pray. And of course, you know, she was perfectly well and her baby was beautifully born. So yeah, but it's not an easy walk. But that's the with woman aspect. That's, you know, you're a consultant midwife, you understand that when you have someone in front of you that's asking for out of guidance care, you know, you're walking with that family and just, you know, wishing them all the best. And that's what we all do. If we respect the family, that's how we all do it. I'm sure most
very much so.
I'm sure.
And I think that journey is very similar, whether you're walking a journey with them where they want to decline intervention or whether they're actually asking for the intervention. It certainly centres very much around just listening and hearing and understanding where they're trying to come from. And I think one of the great things about the women that have been in your care previously has partly been that continuity that they've been able to have from their care provider. And of course, many of us around the country are aspiring to do as much as we can with continuity, but not necessarily to meet a target, but to try and make that really meaningful, so that where we know continuity does improve so many outcomes for women, as well as our experience, that we make that as meaningful as we can and actually help increase that satisfaction and that engagement and that relationship and that communication and that ability to have time to give the resource and the information. Thank you. I've just lost my thread now, but another question I was going to go back to. So some people were posting earlier about how difficult it is to know how much information to give, and whether women want to know everything, should know everything, and what does everything mean. And again, I think sometimes that can come back to listening to that individual woman about how much it is she wants to know and what it is she wants to talk about. I don't know your thoughts on that.
Absolutely, it does. It's not easy, and especially, you know, I'm privileged the way I was able to work. There are many of my colleagues in the services that do not have that time and may not have leadership or that support. There's some amazing leaders of maternity care in the NHS, and then, you know, there's some others that may have been stressed, had previous experiences, you know, got burnt somehow, and so have lost that joy in connecting with families and spending as long as it takes to explain, you know, chances of certain things arising, that especially individualized. I know that's a challenge for us, but I seem to be able to walk that line, and I guess it's the privilege of the continuity of care. I seem to be able to walk that line and be able to say, I'll send you an article, and be able to say, yeah, that's a really difficult decision, you know, with regard to, say, uterine rupture, etc. You know, if you've had 2 cesareans, right? But I think it's the trust is built from the honesty. Like, this is the case, and I can't tell you what your chances are. You know, we've only got a bit of research on that, or we've got small cohort research, but it's the honesty, sharing of that, and then, you know, they can go down to their guts and feel what's right for them.
Yeah.
Sometimes, say if there's a baby that's, you know, really small and they've done all the tests and they found, you know, like the Dopplers are challenged and, you know, the baby's slipping off centiles, etc. Some women say, do you know, I'd rather have a cesarean. If they're that worried about my child, I'd rather have a cesarean. Supporting that choice. Okay, this is how you can have the best, you know. So it's a lot of communicate. It takes a lot of time, and I know a lot of my colleagues that work for units, they just don't have it because of workload. I think that we all work together to try and change the situation for the best for all of us, for the midwives and obstetricians, and for the families.
Absolutely, yeah. I mean, you know, I know we've got many people in our audience tonight who support both as healthcare professionals and outside of, all very supportive and, you
Yes.
know, very much in line with women's right to choose, and, you know, giving the best communication in the way they can. Yeah. Thank you. Thank you so much to everybody for joining us tonight. I hope that everybody has found this a really useful and engaging webinar, and has caused to send us all away to reflect on what we've heard tonight. And please carry on these conversations. Please take what you've heard tonight away and continue the conversation. And we'd love to hear your further thoughts. This will be available as a video on the vBICS website. Thank you to all our speakers for your time tonight. We're very grateful, really appreciate it. We really look forward to seeing as many of you as possible next year in November in Belfast. Thank you very much, and have a lovely rest of your evening. Good night.